fractures. And we found, it didn't work quite as well, basically. So for every standard deviation decrease in trabecular bone score, in white patients, there was a 1.5 times odds of a vertebral fracture. In the black patients, it was like 1.2, didn't meet quite statistical significance. Actually, a very similar pattern that we saw for bone density. So it's a relatively small study, but there really isn't much else in terms of looking at the risk of fracture from TBS. So it was lower, not strongly related to prevalent vertebral fractures in black patients. In the meantime, the National Health and Nutrition Exam Survey, or NHANES, released normative data for the US. And they also reported lower trabecular bone score in black women than white women. In black men, though, there actually were not any racial ethnic differences. So kind of an interesting thing. We don't actually really know why. Some people think it might be related to body shape, or they call it tissue thickness, but we're not really sure why TBS is lower in black women. We actually looked at NHANES data just to see patients who reported a prior fracture in NHANES, did they have lower TBS if they were black or Mexican? So we kind of did this kind of presentation here where we had bone density category, where you see white. This is blue is white. You can see a nice increase in fracture rates with lower bone density and trabecular bone score. For the black patients, normal in osteopenia, not a huge difference in the black and Mexican, but in osteoporosis, you really do see a much higher rate of prior fracture. And then TBS, I don't know, you see a little bit of an increase. With low TBS, you see slightly higher rates of fracture. Again, not very strong though. So, I generally felt like this was a relatively weak relationship, and I don't necessarily use TBS in black and Hispanic patients. So there are some limitations there. We're using prior fracture, relatively small numbers here. And then there are some newer versions of TBS that may better account for body size, but I think they need to do a little bit more work. And I wanted to talk about something a little bit newer, which I find very exciting. It's called 3D DEXA. So there have been a lot of advances in 3D modeling. And this particular company, they've created this software where they have basically a population of quantitative CT scans of the proximal femur. And they basically take a patient's 2D DEXA, and they basically map patient-specific, they create a specific model of the patient's proximal femur, allowing for all these three-dimensional parameters that are typically not available. They also give you these very nice, pretty pictures, like you can see here on the right. And it might be a chance to assess bone structure using just a standard DEXA scan. Again, we had our doubts after our experience with TBS whether this would really work in US patient population. This is a software originating from Europe. So we wanted to looked at this, basically the same population as before, and wanted to look at whether the bone structure parameters were different, and also whether there were associations with fracture. So this pretty much the same patients that I showed you before. I'm not going to go through all these. There are a lot of parameters. This thing is actually trying to directly measure something as opposed to TBS. So there are a lot of parameters. The key thing we thought was that most of the parameters were superior to black patients, just consistent with three-dimensional imaging. And when we look at associations with fracture, we actually found, very interestingly, so in the white patients, this parameter called trabecular volumetric BMD is the most closely related to fracture in the white patients. And this is actually what the company has found with other studies. They found this relationship. With our patients, though, we actually found cortical thickness was the strongest 3D DEXA parameter associated with fractures. That's ties in really nicely to what we talked about before, where that cortical thickness really differs between the black and the white patients. When you look at cortical thickness between those who fractured and the ones who didn't fracture, you can see the Black patients, you can see this red area, that's differences between the fracture and the non-fracture. Versus in the white patients, there's really no major differences in the cortical thickness. So just to summarize bone structure, so TBS does not really seem to capture differences in bone structure in Black patients, may not be as predictive of fracture. 3D DEXA is very interesting, seems to capture some of these bone structure differences. They need to do more work, but it might be useful. And then let's move on to clinical risk factors. So are there differences in clinical risk factors that we can think about? So there's, again, not very much work here. One risk factor that has been looked at has been fall risk. So fall risk is a bigger risk factor in Black patients or Black women than white women. In the WHI, there was a 66% higher rate of fracture versus just 27% in white women. And then they also found, kind of common sense, prior fracture and older age were both risk factors. I wanted to take a little bit of a detour to something near and dear to everyone's heart, diabetes-related fracture risk, and think about diabetes and this question about race and ethnicity. So just as a kind of little bit of an overview, I'm not going to really do justice to this topic, but so what is the connection between diabetes and fracture risk? So for a long time, we've known that patients with type 1 diabetes have lower bone density than those with type 2 or controls. This study came out in 1989. You can see lower bone density here in the type 1 patients. And then when you actually look at fracture risk, you see a very dramatic increase in fracture risk. So for hip fracture risk, there's a 6-fold increased rate of hip fracture in those with type 1. So for type 1, this risk is very well established, very high, definitely should be screening our type 1 patients with bone density. But type 2, it's a little bit of a different story. We kind of thought maybe patients with type 2 don't, we saw the patients with type 2 had similar bone density. In this study, this was a meta-analysis of many studies looking at bone density in type 2 versus those without. And they found higher bone density in those with type 2 diabetes, not by a small margin here. This is about half a t-score. And so you might think, well, these patients aren't really at risk, but it's actually a bit of a paradox. So these patients, despite the higher bone density, actually have higher fracture risk. This has been shown nicely in several different studies. This is one of them. This was a predominantly white Canadian cohort. They were referred for bone density testing, which is something to think about. But in this study, this is a Kaplan-Meier curve, meaning this is fraction without a fracture. So the black line are controls, and then the dotted line is those with diabetes. This is major fracture here at the top. This is hip fracture here at the bottom. And you can see the fracture rate for major fracture was 8% in those with diabetes versus 6%. And then hip fracture is actually even more significant, 2.4% versus 1.3. So really a really significant fracture rate, especially for hip fracture. Again, there's a lot of work in this area. I'm not going to be able to go through it all, but some of the proposed mechanisms here include fall risk. So for example, due to neuropathy or impaired vision, impaired mechanical properties of bone actually seems to be one of the best signals that we have. And that means the bone is literally more brittle. And that's really difficult to measure in the clinic, unfortunately, but that seems to be the strongest signal. There are some other studies suggesting microarchitectural changes, though they are not consistent. There's also been thoughts about bone turnover or the effect of diabetes medications. I do think, when we think about our diabetes complications, I do think we should start adding bone fragility to this list. In fact, I'm really happy I saw the ADA actually has added bone fragility as part of their standards of care, including additional screening and treatment. And so getting kind of back to what we were talking about, race and ethnicity, we know that diabetes burden is not the same among all races. So Black and Hispanics have almost twice the rate of diabetes. Not only do they have higher rates of diabetes, they have higher rates of complications. So various studies have shown higher rates of proteinuria, retinopathy, and amputations compared to whites. So what about diabetes-related fracture risk? Maybe that risk is higher too. Really hadn't been very much work. This is one study. This was a kind of a small study. This was a follow-up study to N. Haynes. They looked at non-skull fractures. You can see relatively small numbers here. But they did actually propose an increased risk of diabetes-related fractures in Black and Mexican Americans. Again, I was a little skeptical of this study. It was really small. So I wanted to do my own work. So this was actually a study I did while I was in Philadelphia. So we looked at patients presenting for routine care, patients with diabetes, and we used hypertension as our control. And these were, again, patients being seen routinely for care. Some exclusions for CKD, bariatric surgery, and transplant. And we looked very specifically. So a lot of these fracture studies in diabetes, they looked at all fractures, which can be a little bit problematic because we know ankle and lower leg fractures are very closely tied to weight and fall mechanism. And so those are going to be higher in patients who are overweight. So you really want to focus on what we know are fragility fractures, which are things like humerus, wrist, and hip fractures. So these were the patients that we included. Again, relatively decent numbers. Patients were older in their 60s. Unsurprisingly, the patients with diabetes had higher BMI. You can see the follow-up was about 3 years. And then Charleston comorbidity, I just want to point out again, patients with diabetes were sicker than those with hypertension. Actually, diabetes is with complications actually in Charleston comorbidity. There's a little bit less of a spread in the Black patients. I thought that was an interesting observation. And then looking specifically at the severity of diabetes in the patients, we can again see differences in Black and Hispanic. We can see that diabetes is more severe in the Black and the Hispanic patients. They have higher rates of hypoglycemia, higher A1Cs, higher insulin use. So definitely a little bit sicker. This was the cumulative incidence of fracture over time. The red curve here are the Black patients, and you can see that Black patients with diabetes, they did. When we controlled for a couple of different important risk factors, we found in the white and Hispanic patients, there was a 23% increased rate of fracture in the white and Hispanic patients with diabetes. But in the Black patients, we actually did not find any diabetes-related fracture risk. So we're not sure if there was that, we saw that difference in the spread between hypertension and diabetes. I don't know if that was contributing to us not seeing a difference, but we didn't see it. And I wanted to actually come back now. So we're talking a little bit about fracture risk, and what about fracture risk calculators in people with diabetes? So studies have shown that fracture risk calculators are less accurate in people with diabetes. So these are called calibration curves. So I'm going to be showing a bunch in the next couple of slides. I just wanted to show what they were. So what they are is essentially on the x-axis, you have predicted risk. So that's what the calculator says the risk is going to be. On the y-axis is the actual observed risk. And then right here at this dotted line is a 45-degree line. So that essentially means perfect calibration. That means observed and predicted match perfectly. When you have a line like this gray line above this 45-degree line, it means the risk calculator is underestimating the actual observed rate. So in this study, they did find underestimation in those with diabetes, kind of across the FRAX continuum here. So this was from that Canadian group. Again, Canada, these were patients referred for bone density. So no published study has examined US racial subgroups with diabetes. So we're actually collaborating with Kaiser Permanente, examining about 100,000 patients with diabetes. And I wanted to share this data with you. This is not published yet, but these was the cohort that we used. These were men and women over the age of 65. Some exclusions for kind of short-term diabetes, patients with end-stage renal disease, people on osteoporosis meds, we excluded. This is our final cohort, kind of almost exactly 100,000. And then these were their kind of all the patients here on the first column, and then divided into no fracture and fracture. And you can see, not surprisingly, the people who fractured were older at baseline, lower BMI, a little bit more white patients than those who fractured. And then you can see a little bit trend towards greater diabetes duration in those who fractured. So how did the calculators do? I'm going to focus on the race findings here. So actually the discrimination was relatively similar, again, between all the different racial ethnic groups. So again, this means the calculator is sorting high risk from low risk adequately. Now, what about, so this is the calibration curve I showed you earlier. So again, predicted risk on the x-axis, observed risk on the y. And you can see this curve kind of starts to skew above the 45-degree line in the highest risk groups. So in the highest risk groups, probably the most clinically relevant groups, there was some underestimation of risk overall. Oops. When you look by race, we actually saw some very interesting findings. So in the white patients, pretty much mirror the overall findings, but in the Black patients and the Asian patients, you actually see pretty good calibration here, actually pretty close to this 45-degree line, meaning observed and predicted were pretty similar. But then look at the Hispanic patients. So this was kind of wildly underestimating the actual fracture rates in the Hispanic patients, almost by 2/3. So really stark. This was for major fracture. When we look at hip fracture, again, Hispanics you see maybe not quite as severe, but still an underestimation in Hispanic patients with diabetes. And then in the Black patients also we saw some underestimation. This is a pretty big cohort. So this is, I was a little bit surprised at the performance here for Hispanics. So just to kind of summarize diabetes, so for major fractures, we found that diabetes-related fractures might be less important in Black and US Asians than whites. And then we also found that FRAX substantially underestimates major fractures in Hispanics with diabetes and hip fracture in both Hispanics and Black subjects with diabetes. Some of these findings are actually kind of similar to what I found in the general population. So it's not clear if this is a diabetes-specific problem or kind of relates to bigger systemic issues with FRAX. And I kind of wanted to leave, kind of considering this question that talked with some of you today about this is kind of, are there better ways of examining fracture risk? So FRAX, you know, it's a nice tool, but it does require manual entry and time. It's not part of our normal clinician workflow. And one thing I've been interested in is now that the electronic health record is such a central component of how we work, could you actually predict fractures using information already in there, kind of without having to verbally ascertain these different risk factors? You can also incorporate a lot more risk factors into the fracture calculator if you use the electronic health record. So kind of as a proof of concept, I wanted to look in some of our data, and so this was, we actually took the prior population I showed, we validated FRAX, we split it into a derivation group and a test group. So this was about 3/4 of the patients, 18,000 patients. We looked at a whole bunch of different things. I'm not going to go through each of these, but you can see on the right the type of category. So, you know, EHR really has a lot of data in it. So demographics, vitals, utilization, diagnoses, meds, and labs. So we looked at a lot of different things that could predict fractures. This was our final model. And then what we did was we tested it in the 6,000 or so patients that we did not use to create the model. Oops. Oh, and as a side note, we did include race, by the way. So it's interesting. In Black, we actually found almost exactly the same risk as FRAX. And so in the 6,000 patients that were not used to create the model, we tested the discrimination. We found relatively similar performance as FRAX. And then when we looked at the calibration in this test set, this is kind of a table version of those figures that I've been showing you. Pretty much we found the observed to predicted ratios were 1 for both us and FRAX. And then if you look at by race, you do see kind of maybe slightly better performance in the Black patients in our calculator. And this is the nice thing about this was a proof of concept, so this is certainly not the final word. I think you would need to include a lot more geographic diversity to really get a good tool. But even with a relatively small cohort, we can match the performance of FRAX without any time commitment. So kind of a summary and hopefully a practical approach. Sometimes I feel like I give information about these work, and I think I'm bashing fracks. So I actually do think fracks can be really useful as an anchor, but there are some problems in minority patients. So we demonstrated some stark underestimation in Hispanics and Black men. If you're in the clinic, if you aren't sure what to do, if you have a fracks, if you double the fracks, whatever you have, that'll pretty much give you the white estimate, and that might be a good rule of thumb when you're talking to patients. Also, our calculator doesn't consider any outcomes after fracture. So some of these bone structure tools could be useful, may help capture some of the differences in minority patients. And then just in diabetes in general, lower threshold to consider bone density testing. Physical function evaluation, I always recommend for our fellows, can watch the person walk. If this person can't walk down the hall well, that tells you that they're at fall risk. Have them stand on one leg. As I have almost every patient in my clinic stand on one leg for 20 seconds and see how long they can do it for. Those are all things that can help you predict fractures outside of these calculators. And then finally, I think there's going to be more and more new methods to evaluate fracture risk. I showed you one with electronic health records. With AI, I'm sure there's going to be many new things. I think the key thing is we want these things to be easy within our workflows. We have to make it easy for everyone to evaluate patients. So with that, I thank everyone. These are some of my collaborators and mentors, both here at University of Chicago as well as at other places. Some funding here on the right. And then I did want to just very quickly for the fellows, I'm actually part of this faculty group. We're launching this thing starting in March with the Endocrine Fellows Foundation. It's going to be a bone telehealth conference. It's going to be once a month. It's me, Steve Petak, Ann Melbas, and Jillian Woodbridge. And it should be really good. ECHO is kind of this everyone learns, everyone teaches format. It's basically a short didactic followed by cases. It's open to endocrine fellows nationwide. So I just wanted to encourage you all, if you're interested, there's just the Endocrine Fellows webpage. They actually have more information there. So with that, I thank everyone. Thank you for the invitation. I've really enjoyed my day here today. I'm happy to take any questions.
That was fantastic. And do you have?
I have just.
Oh. All right. If we have any, I'll talk loud enough so even that microphone can hear me. If there's any viewers virtually, you can either unmute or enter into the chat. So we'll look at that. I guess I'll start by saying great talk. Just a question about fracks and T-scores. I mean, the current recommendations are if you've got a T-score in the osteoporotic range, treat, and if you have osteopenic T-score, use fracks.
Yeah.
I mean, you showed us that there's some problems with fracks with different racial groups. I mean, would you lean towards the opinion that some people have of maybe we should just use fracture risk throughout the spectrum of T-scores, or?
That's what I do, honestly. Like, I don't know. I think they want to encourage people to treat patients with osteoporosis, and there's definitely something to that. And obviously I showed osteoporosis treatment rates are very low. But I think there's plenty of women who are, especially 50-year-old, 55-year-old women who are very low fracture risk, even if they have osteoporosis. You don't have to treat those patients with osteoporosis medications. I mean, maybe estrogen, but you don't necessarily need to use bisphosphonates in people like that.
Yeah. We have a question from the chat. So did you find differences within the Asian groups, et cetera?
Yeah, so we did not specifically look at the Asian subgroups. Important limitation of the work. One of the collaborators in that project, her name is Joanne Lowe. That's kind of her work. She does a lot of work in Asian subgroups, and she actually has found very important differences in different Asian subgroups. So I was telling the fellows earlier, they found I think Filipino was the lowest fracture rate of all the Asian subgroups. Then South Asian actually had higher fracture rates than the other Asian subgroups. So there are important Asian groups, but we didn't look at those. Yeah.
So you didn't touch on the breast cancer therapy, and I'm sure the same kind of differences probably I mean, the practice itself is not very good when you're, for anti-estrogen therapies. Any literature on the other racial groups?
Oh, like the,
I think at least the FRAX, they say you check as patients having rheumatoid arthritis or something, so that it accounts, because FRAX doesn't really.
so for women on like
Yeah.
aromatase inhibitors, is
Yeah.
that what you mean? Oh, okay. I actually don't know if there's any specific studies looking at, actually, I want to say there was a study looking at aromatase inhibitors and actually maybe overestimated fracture rates, but it's tricky because a lot of those women end up getting treated,
Right.
So I don't know. I think it's probably, I have a lot of respect for the effect of aromatase inhibitors on bone density. I've seen women lose huge amounts of bone on aromatase inhibitors. So I think there are some guidelines out there that recommend treating even if the T-score is like less than -1 or -1.5. I don't think it's a bad idea. I mean, you can get really fast bone loss on aromatase inhibitors. But I don't specifically know if FRAX. I don't know if FRAX is the right tool to be using obviously in treatment, because it's just the rate of bone loss is going to be really high.
Other questions?
I had two questions.
Sure.
One was, so you talked about trabecular bone score and
Yeah.
between races. I'm wondering if anyone has looked at like opportunistic CT when you're comparing it between different races.
So I actually did a study opportunistic CT once. It was actually in diabetes. It was pretty similar between we were looking specifically like diabetes versus hypertension, but we looked at the race and it wasn't a huge difference. Actually, the only group that we found a slight difference, I think this has been published, Asians, we actually found worked a little better, and we thought maybe it was related to less degenerative disease in the spine and among these patients that we had anyway. But yeah, that's the only study I'm aware of, but there's a lot of opportunistic CT studies I'm not familiar with. So I could be wrong. There could be other work.
And the other question I had was, when you were talking about, I guess, the 88 guidelines for 24, and they're talking about looking at patients' bone density more. I remember when I was reading them, there's like a line in there where basically it talks about how maybe we should look using T-scores of -2.
Yeah.
With diabetes, and I wonder, is that like something you incorporate in practice, where like if a patient has diabetes and their T-score is like -2, you're like, this person has osteoporosis, or?
Yeah, I definitely have a lower threshold to treat the patients with diabetes who are high risk. Some people have proposed using kind of different adjustments to FRAX to account for diabetes-related fracture risks. So some of the proposed adjustments to FRAX have included like half a T-score, increase the age by 10, and probably the one that I've seen the most is checking off rheumatoid arthritis as a proxy. Those were tested in one study, and they all did okay. They all kind of improved things a little bit. But then if you have patients with really long duration diabetes, they still had higher fracture risk than estimated. So those things are okay. I think they're kind of better than not doing them probably. But I think there's a lot of heterogeneity within diabetes, and I think that's probably what's driving the fracture risk. And so I just don't think you can really properly calculate fracture risk with FRAX without like more diabetes specific risk factors. So I think eventually there has to be a diabetes specific risk calculator, or at least some incorporation of diabetes related factors. Yeah.
I have a couple of questions. I think we kind of talked about this earlier, but so kind of piggybacking off of that, in terms of like diabetes duration, has anyone ever looked at like peak bone density in particularly the type 1 population, right? Because they get diagnosed much earlier, and looking at their peak bone mass, which we assume, is roughly between age 20 to 30, somewhere in there. Has anyone looked at that you know of?
I'm sure there is, but I actually don't know off the top of my head.
I'm gonna have to go back and look at it.
When I talk to patients, I always, you probably did not get, especially for the ones who were diagnosed young, I mean, insulin is kind of an anabolic hormone, and so like you gain mass, and a lot of these type 1 patients are really underweight, and so I think that contributes a lot to their low bone density too. So some people have said, well, is it just duration? Is it just But I think maybe yes, duration is an important piece of it, but I also just think having diabetes during bone development, as you're suggesting, is really important. But yeah, I think type 1, it's outrageous. Sometimes the patients that I see with type 1 that have hip fractures, like 65, 60, really quite young for a hip fracture.
With your Kaiser data,
yeah,
did you separate out type 1, type 2, or just all?
We had only 800 type 1 patients.
Okay,
yeah, so we did do a sensitivity analysis excluding them just to make sure that wasn't like driving some of our findings. It wasn't. Yeah. But we didn't have enough to like really do a good analysis. Yeah.
And then what about, can you go back to the slide with the drugs that those patients were on? I forget what year that was, like where that data was coming from, but like SGLT2s, which.
Oh, this study. Yeah, this was, gosh, we probably pulled this data. It was like probably 2011 to 2017.
So it was
before like the really wide. I think I did try to see if we had enough GLPs, but we didn't have enough GLPs. And definitely not enough SGLT2.
Yeah, because I'm with the concern for loss of muscle mass with the GLPs, the fracture risk with SGLT2s, and then you do have the TZDs.
Yeah, we actually did in this study. I didn't show you. We actually did. TZD was actually one of the strongest risk factors for fracture in this study. And actually, even in the general study, they did. These were not the same population. So actually, TZD actually made it onto this too. This is in general patients. So in this population in North Philadelphia, it was a really strong risk factor. Yeah.
Hi, Dr. Jain. This is Denise. I have a couple of questions. The first one is about CKD patients. It's really difficult to assess them, especially end-stage renal disease and kidney transplant after being on hemodialysis. Do you have any data about TBS scores? How useful are those in these patients, and the same for FRAX?
I want to say I think there's data, but I am not familiar with data for end-stage renal disease and TBS. To be totally honest with you guys, I don't think very highly of TBS. I think it's okay. I think it's okay in the white patients, but I don't know. I think there's a lot of limitations, especially in people who have some belly fat. I just think it may not be very helpful. So I look at it, but I don't necessarily use it to really change treatment decisions. Just generally speaking, like the patients who are renal transplant patients, I think a lot of those patients will have a little bit of PTH still. It takes a while for that tertiary hyperpara to resolve. And I usually just let it resolve. I don't usually, not very aggressive. I definitely don't send them to surgery. I don't use PTH drugs usually in those patients. I haven't used romosozumab, but I don't think there's a reason you couldn't. I think it would probably be a good choice. I have used romosozumab once or twice in patients with end-stage renal disease. So I don't have a very large N, but it's in theory a bone formation and a bone resorptive. It affects both. So it shouldn't really be affected by the type of renal bone disease. This is all theoretical, though. Obviously, I don't do it nilly-willy. It's kind of patients who are really high risk for fracture with end-stage renal disease.
Are you using that in patients that have already fractured, or just super high risk?
Usually people who've already fractured. I just have a hard time using drugs that are not, really been that well studied in that population without having someone who's already fractured.
Thank you. And my second question is about the type of fractures in diabetic patients.
Sure.
I saw your graph about humerus, hip, vertebra, wrist. I tend to see in my practice more lower extremity fractures like metatarsals, ankles. So have you studied those as well?
I looked actually in that study. I actually did look at ankle fractures, and they were higher in the diabetes patients. But ankle fractures, I don't really consider fragility fractures. They're not really tied to bone density generally. I think it's more fall mechanism. So yeah, I think you're right. I think lower leg, ankle are higher. They're higher. They happen more often in diabetes. I don't know if if you treated that patient, I don't know if you're really going to lower their risk of an ankle fracture. The other fracture that's been seen, all these fractures we've seen a lot, but the ones site specifically humerus fractures are actually one of the more common fractures in patients with diabetes. Not as much wrist as far as I know.
Thank you.
Yeah, why don't you go?
Any questions from the room? So going back to the definition of, as you pointed, actually, and also nice presentation by the way, on the definition of race, it's a social and biologic construct, right? So I'm just wondering, what would you do I have two scenarios. If you had a patient who's not black and he's not, or she's not black or she's not white, she's actually mixed.
Yeah.
And the second scenario, I had, for example, a patient who's coming from the Middle East. I don't remember whether it's Lebanon or Egypt, and they've been in the U.S. their whole life. And so, would you put them? And if you put them as a white, then they would need treatment. If you consider their home country flag, then they don't need.
Yeah. Those are good questions. Yeah, so I'll take the second one first. So I will say that I think I know there is data looking at immigrants, and it seems like when people move to a new country, they adopt that country's fracture rates. I don't really understand this, but this is what the studies have found. So I probably would use like the US calculator. I don't know what I would call that person though from the Middle East. I don't know if I would call them white. I don't know. That's a tough thing. Sometimes I'll use fractions like an anchor. Like, okay, this is the baseline risk. Maybe their risk is a little bit lower than this, but at least gives you like something to kind of start with. Mixed is a very challenging thing, and it's becoming more and more common, of course. So I will typically pick, if the patient self-identifies as one, I'll obviously use that to calculate the fraction. But if they tell me, oh, I'm actually mixed, between two, I'll try to create some kind of average or blended version of fracs to kind of help, if I need it to help counsel the patient. If I need it for my own risk assessment, I'll think about it that way. Obviously, I'm using things other than just like fracs to make decisions. So you should, you're using, physical function evaluation, et cetera, to help decide, and obviously patient preferences. But yeah, if I really needed to tell the patient, what is your fracture? If they ask me, what is your fracture? What is my fracture risk in 10 years? I'll kind of give them an average. Yeah. And these are good questions. These are things I've thought about all the time.
Great. Any other questions? Well, thank you again. Great.
Thank you, everyone. Oh, nice.
Diabetes, not diabetes, just over the counter. You see the Dexcom got the FDA clearance for their over the counter. I don't want to think about the
You don't want to think about it.
people that are going to show up.